Hello and good evening, everyone. Welcome to our 58th Blue Hills virtual seminar. Blue Hills virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Hills Ethiopia, a medical consultancy company founded by medical computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Zeynu, a general physician and first aid trainer from Blue Hills, Ethiopia. Today, it's a pleasure to have Dr. Zeynu Hussen here with us to present on the principles of damage control resuscitation. Dr. Zeynu Hussen is an emergency medicine critical care chief resident at Haramaya University.
Okay, thank you, Dr. Zeynu. So we can proceed to the presentation. He already introduced me. I am the critical care and emergency medicine resident here in University of Haramaya. So today we will have presentation on the principles of damage control resuscitation. So we have the outlines of the presentation. We have the objective and physiology of trauma and introduction to damage control resuscitation. And we'll see the phase of damage control resuscitation and the concepts of the massive transfusion protocol. So after having a discussion of this topic, everybody able to know the some physiologic response to trauma and able to know about the lateral triad of the trauma, and we should able to know the concepts about hypotensive hemostatic resuscitation principle, and able to know the different phases of the damage control resuscitation, and able to know the concepts of the massive transfusion protocol. So coming to the physiology in trauma, as we know, our physiologic system can be affected by both the external as well as the internal different factors. And the derangement in physiology depends on the mechanism and severity of trauma, so that the degree of the derangement can be varied based on the severity as well as the mechanism of the trauma. And most commonly, as we know, according to the advanced traumatic life support, the last edition, whenever a trauma patient present with shock, the top 3 causes of shock should be hemorrhage, and hemorrhage for the 3rd times. And we need to consider other causes of shock after having the consideration of hemorrhage. So then after that, we can think about the next other possible causes of shocks: the cardiogenic, pneumothorax, cardiac tamponade, and neurogenic. So in diagnosing shock, hemorrhagic shock, we should never rely on the blood pressure alone. Should keep in your mind that there is no single most important vital sign in diagnosing shock, but rather it's the holistic approach of the patient as well as the whole vital signs, including the shock index, the capillary refill, the peripheral perfusion, the urine output as a whole gives a clue for diagnosing shock. But rather, we shouldn't rely on the blood pressure alone for diagnosing traumatic shock, so that there is no single most important vital sign for diagnosing shock. The reason why we shouldn't rely on blood pressure alone is one thing due to the compensatory reflex that's going to mask the degree of hemorrhage. As we know, whenever a patient loses blood, there is a compensatory reflex that's present on the carotid sinus, the aortic antibaroreceptor. That sends the low pressure receptor and leads to the sympathetic nervous system activation, which later leads to the increment in the heart rate and the peripheral vascular resistance, which intends to lead the increment in stroke volume and cardiac output so as to compensate the hemorrhage. So hemorrhagic shock generally can be classified into compensated as well as compensated, and about 10 to 50% of the blood loss may be adequately compensated by the physiology alone. This is a good thing. So we have like 4 classes of hemorrhage based on the estimated amount of blood loss as well as the different vital sign parameters. Like class 1, we expect blood loss to the level of 50% or 750 ml, class 2 to 1.5 liter or 30% of the whole blood, and class 3 up to 2 liters, and class 4 up just more than 2 liters. And here we have different parameters like the pulse rate. When we see the pulse rate in class 1 hemorrhage, we expect the pulse rate to be less than 100, and in class 2, 100 to 120, and class 3, 120 to 140, and in class 4, greater than 140. So the blood pressure might be normal in case of class 1, class 2 due to the compensatory reflex mechanism. And generally, this classification couldn't guide resuscitation, particularly in emergency department, because of several reasons. One thing, patient like who have young athlete patient who have robust physiological response may not show, even for significant amount of blood loss, may not show like tachycardia or hypotensive. Another thing, like elder patients who may have underlying cardiac disease may not show tachycardia, self-relax, or patients on beta blockers may not show tachycardia as well as the hypertensive early. And another thing, like 30% of intra-abdominal hemorrhage trauma patients may show despite tachycardia, not rather tachycardia, but they present like bradycardia due to the vagal tone. And another, like when you see pregnant women, because of the gravity plus compresses the venous return, for that matter, the patient may be hypotensive and tachycardic despite less amount of blood loss. For this reason, this classification of hemorrhage, degree of hemorrhage based on the vital sign couldn't be used for resuscitation in emergency department. But this makes sound for like operative theater. Whenever there is a strict follow-up, the amount of blood loss, we need to anticipate the massive transfusion. For that matter, we can use for resuscitation, particularly in the operative theaters. And generally, when we have class 3 and class 4 hemorrhage, this is a thing to consider like massive transfusion protocol, since the patient had lost more than 30% of blood. For that matter, we need to consider the massive transfusion protocol. Will come what massive transfusion protocol to mean. And coming to the one of the deadly traumatic types of trauma, the acute traumatic coagulopathy. This is the complex inflammatory factor versus the intrinsic anticoagulant interaction and other functions. Generally, coagulopathy can be classified into two. One is the trauma-induced coagulopathy, some say trauma. Another, the extrinsic or the resuscitation-induced coagulopathy, which is caused by like dilution to the resuscitation or the hypothermia from the external factors, or the acidosis, tissue hypoperfusion generally can cause the extrinsic or the resuscitation-induced type of the coagulopathy. So the large volume of fluid and unbalanced component of blood therapy can result in the resuscitative induced coagulopathy. Generally, the difference between the traumatic-induced coagulopathy and the disseminated intravascular coagulopathy, based on the laboratory parameter, those two things have similar features. Both may have life-threatening thrombocytopenia, both may have low fibrinogen level, both may have high D-dimer level, but the thing just to differentiate between two of them is we need to see the patient. Otherwise, there is no laboratory value that able to differentiate between the traumatic-induced coagulopathy versus that of the disseminated intravascular coagulopathy. And then traumatic-induced coagulopathy, generally, it's not a disseminated type, but rather whenever the trauma sustains to the specific part, it's just restricted to the traumatic part, and it's not disseminated. And it's not also intravascular, but rather it's extravascular due to the extravascular trauma. And it's not coagulopathy, but rather it's a bleeding. So the thing just to differentiate between them is the clinical picture of the patient, not rather the laboratory values. And traumatic-induced coagulopathy, it's not only occurred due to the resuscitation, as previously discussed. Sometimes even it can occur within 30 minutes of the injury, particularly in 25% of the patient having severe trauma may have this traumatic-induced type of coagulopathy within 30 minutes of the injury. And it could be also the result of the physiological derangement, such as the acidosis, hypothermia, hemodilution due to the blood and the fluid and the blood administration. And however, acute coagulopathy can also occur in severely injured patient independent of those additional factors. So generally, it's attributed to the dysregulation of the thrombomodulin protein C system characterized by factor deficiency, hyperfibrinolysis, and platelet dysfunction as the typical feature of the traumatic-induced coagulopathy. Whenever we have sustained trauma, patient may develop shock, deadly triads, and tissue injury. This thing leads to the endogenous response, an increase in the activated protein C, the endothelial glycocalyx disruption, which leads to the release of heparin-like molecule, and autoheparinization will be occurred, and platelet function. One thing is because of the hemodilution, other thing is the DIC, the traumatic-induced coagulopathy, and fibrinogen also depleted. Those are the things that endogenous response will happen for the trauma. This again leads to the acute traumatic coagulopathy, which has like autoheparinization, hyperfibrinolysis, and reduce the clot strength and reduce thrombin formation, which leads to the bleeding tendency of the patient. So these are the pathophysiology of the traumatic-induced coagulopathy. Whenever trauma sustains to the patient, the endothelium will be activated and thrombomodulin will be expressed. So that thrombomodulin forms complex with thrombin. So that thrombomodulin thrombin complex leads to the activation of protein C. This protein C has a preventive effect of the bleeding, so that it's anticoagulant. So this activated protein C leads to the activation of the plasminogen activator inhibitor 1, which leads to the degradation of fibrin, so that bleeding will happen. And these are the summary of how the traumatic-induced coagulopathy will occur. So compared with patients who do not have coagulopathy, generally coagulopathy patients have a 3-fold greater mortality and are going to have 8 times more likely to die within the first 24 hours of following injury. And another terrible traits of trauma is the hypothermia. As we know, due to the following, due to different reasons, hypothermia can occur in the background of trauma patient. So they have a lot of reason to be hypothermic. One thing, due to the cold exposure at the time of injury, another during transportation, another during examination when the gets undressed, and another during resuscitation with cold fluid are the particular cause of the hypothermia on the background of trauma patient. So we can grade hypothermia based on the temperature, the mild 34 to 36, moderate 32 to 34, and severe as less than 34 degrees centigrade. This grading has great importance, particularly for predicting the severity of the coagulopathy. For example, whenever the patient had temperature of less than 30 degrees centigrade, the primary hemostatic function of the platelet will be lost whenever the patient goes temperature less than 30 degrees centigrade. And platelet dysfunction will happen, enzymatic dysfunction will happen. For that matter, go to the vicious cycle of bleeding. And what measures should have to take is we need to control our physical exposure. We need to administer warm fluids to the level of human body temperature or more, even up to 38 degrees centigrade. Warm fluid should be administered. And we need to keep passive warming through blankets, forced air device, or a lot of other reasons. And having said this, let's come to today's main topic, the damage control resuscitation. Generally, damage control resuscitation principle is a damage control dates back to the World War I, with the United States Navy Force try to fix their ship. And they try to fix the most critical part of the ship, that is floating, rather than other issue. The first goal was to keep the ship just from sinking. So the concept borrowed from the US Navy Force and applied to the human medicines, and in the 1980s it was applied. This was the ship that got damaged, and they tried to fix the most critical part that prevents it from sinking, but rather not just other issue. So let's ask one question. 28 Mr. X sustains RTA 30-minute back and present to the ED with ambulance, and was having IV line in place, fluid was running fast while at ED triage. The officer saw him and he called the AD practitioner. When you saw him, no issue on A and B on circulation. He was having hypotension of 70/50, pulse rate was 120, and it was fever cold. GCS was having altered mental status, no other pertinent finding on exposure. He was having shivering and bleeding over the lower abdomen and thigh. So how would you proceed in management of this patient?
Participants can write their answers on the chat box. Yeah.
Okay. These are the entry questions, so we will get answers throughout discussion. So coming to the principle of the damage control resuscitation, generally damage control resuscitation is a treatment strategy. The main target condition that exacerbate hemorrhage in trauma patients should be treated. So the mere focus of the damage control resuscitation is just to treat the exacerbating hemorrhage. So this can be done through three things. One thing, we need to recognize the bleeding and stop it through different modalities. And based on the severity, we can consider the activity of the massive transfusion protocol. Will come what massive transfusion protocol to mean. And the second thing, we need to restore the blood volume rapidly and effectively. But think about the potential resuscitation principle. It doesn't mean just making the blood pressure normalized, rather allowing some hypotensive to the level of systolic 80-90 is our goal. So as to restore the blood volume rapidly and effectively, we need to consider the damage control resuscitation principle, which is the hypotensive resuscitation protocol. The third thing is hemostatic resuscitation. Hemostatic resuscitation is to me limiting the intravascular expansion, plus just not normalizing the blood pressure when it is in the lower normal range. Those are the three things that we need to focus on the damage control resuscitation. And we have some indications which patient needs damage control resuscitation. Generally, there is no agreed upon hard and fast rule which patient is going to from damage control resuscitation, but according to the experts' opinion, they thought that severe degree of physiologic insult are one thing that needs the damage control resuscitation principle. Generally, this should be applied to the polytrauma patient, and the severe degree of physiologic insult is defined by acidosis of pH less than 7.2, coagulopathy of INR greater than 1.5, and the hypothermia less than temperature of 34 is defined as the severe degree of physiologic insult. And also in the operative theater, patient develop the ventricular arrhythmia is considered as a severe degree of physiologic insult. For that matter, we need to this patient needs the damage control resuscitation. So another indication is if the patient needs for internal packing to control the bleeding, like the liver injury patient, they may benefit from the internal packing. For that matter, we need to anticipate the massive transfusion protocol plus the damage control resuscitation principle. Another, the need for large volume of resuscitation, like 10 units of blood, is one of the things we need to consider damage control resuscitation. Another, difficult injury pattern during surgery, particularly for those having retroperitoneal hematoma, pancreaticoduodenal injury. Those are the things considered to be difficult injury pattern. For that thing, we need to apply the damage control resuscitation principle. And another, the need for staged abdominal as well as thoracic contraction, like abdominal trauma who have compartment syndrome or the bowel or edematous. We should have to wait for the edema subside and later we will close the abdomen. For that matter, those are the basic things that written as indication for the damage control resuscitation. And generally, damage control resuscitation is not a one technique, but rather it's a group of strategy which addresses the several types of trauma, which is the coagulopathy, acidosis, hypothermia. And it's a combined resuscitation plus surgical. Under damage control resuscitation will come 4 phases, and surgical is also part of the resuscitation. So damage control resuscitation has 5 components. One thing, the permissive hypotensive resuscitation protocol. another thing, the bleeding control technique, and another hemostatic resuscitation is just to mean limiting intravascular volume expansion with a low normal blood pressure target. And another, we need to minimize the crystalloid use. Those crystalloid has a lot of adverse effects, including acidosis or AKI. For that matter, they also expand the intravascular space and pop up the clot, and it may worsen the bleeding. And another is early airway control is also under the damage control suspension principle. So those are what we discussed. So the principle were used originally in patients with penetrating abdominal trauma, but nowadays it's extended to the like thoracic vascular injury factors or other injuries who have severe physiological derangement. And coming to permissive hypotensive resuscitation principle, permissive hypotensive resuscitation principle is just to mean keeping the blood pressure to low enough to perfuse the end organs while avoiding exsanguination. Just to mean keeping the systolic blood pressure to the lower normal range in 80s and 90s, so as to avoid exsanguination. This is clear why whenever the blood pressure increases, the clot will be disrupted, pop out, and bleeding will be worsened. For that matter, the permissive hypotensive resuscitation principle should be used. That's as important to prevent the clot disruption and also avoid over dilution through excessive fluid administration. Those are under the techniques of permissive hypotensive resuscitation principle. We need to avoid overuse of the fluids. And the canon is a well-known surgeon, tell us in the 19th century, like whenever the pressure rises, while the surgeon is not ready, that's blood that needed to be will be lost. So whenever an increase in ventricular preload, that leads to increase in blood pressure, which may reverse the vasoconstriction, and that may displace the early fibrin clot. The clot will be popped out and bleeding will be worsened. For that matter, permissive hypotensive resuscitation principle should be used to keep the blood pressure in the low normal range. Our only focus is to the vital organ, perfusing to vital organ till the bleeding is controlled. So at the same time, the provider can take the advantage of the compensatory response. Vasoconstriction in the non-vital region redirects the most important organ. So the ultimate goal is to benefit from this compensatory mechanism as long as possible, but when this works is not still well studied. And consequently, there is some expert consensus to tolerate systolic blood pressure of 80 to 90 in trauma. This is the hypotensive resuscitation principle. But hypotensive resuscitation principle will not be used in patients like myocardial disease, cerebral ischemia, or traumatic brain injury, because they may get worsening of injury from permissive hypotensive resuscitation principle. So we shouldn't use for those patients. And it's imperative to acknowledge that permissive hypotensive is neither treatment nor substitute for surgical bleeding control, but it's just to buy time until the bleeding is controlled. So these are the diagram which illustrates trauma trade of the death. As we see, whenever there is hypothermia, there is a decrement in cardiac output, which leads to bradyarrhythmia, and which again leads to decrement in function of the coagulation factors and platelets, as previously mentioned. Like we take example, temperature less than 30 degrees centigrade may lose the primary hemostatic function of the platelet will totally be lost. And the acidosis, which later reduces the contractility, which leads to decrement in cardiac output, bradycardia, dysrhythmia can happen, hypotension, and a decrease in function of coagulation factor and platelet will also noted in the acidosis. So those are the vicious cycle of the treble threads of trauma. So coming to the different phases of the damage control resuscitation in the perioperative period, generally damage control resuscitation has four phases. We'll come on that. The first phase is just rapid transportation and some the ED resuscitation. These are the phase 0, considered as phase 0. It starts from the peri-hospital setup. Whenever the trauma will or the causality happens, particularly in the Western, the AMS should deliver the patient early, so he will get benefit from the time. So the phase 0 is happening just in some part of the ED resuscitation plus the peri-hospital setup. In the peri-hospital, it includes disrupt transportation and focus to the most life-threatening part like airway and circulation. So resuscitation can be started in the peri-hospital setup. Airway can be controlled in the peri-hospital setup. And the phase 1, which can happen in the operative theaters, which leads to the control of the life-threatening hemorrhage and contamination. Those are the phase 1. And phase 2, from OR again, they go to the ICU and they go to resuscitation, the physiologic normalization level. And the last phase is the definitive management of injury or reconstructive phase. So early in the first phase, patients suffer from the uncontrolled hemorrhage. Second phase begins when at least partial pulsation has been achieved in the OR. And the third and the last phase is when the patient physiology starts to normalize. So as we discussed, phase 0 is a peri-hospital setting and part of ideal suspension to the and go to the OR. And during this time, patient got like the airway control intubation should have taken in the emergency department, or if there is MS available, it should also possibly to happen in the peri-hospital setup, and crude resuscitation also should be started here. And phase 1 at the operative theater, with the main goal is just to focus the main bleeding part to be controlled. That one is the main focus. And phase 2, the ICU, with the consideration of prevention as well as treatment of the treble threats of trauma. And phase 3, again, they go to the OR for the definitive management. And phase 4, again, to the OR for reconstructive phases, which may happen like a week or a month back. So what things should have to be done in phase 1 is start with transporting patient from the site to the hospital. While on ambulance, it's essential care must be provided for us to limit the bleeding. So they will pack the bleeding, they will secure line, and if, as previously mentioned, MS available, any fractionals that can intubate patient available, they can consider intubation. And the goal of this phase is expediting the patient to hospital while providing the life-saving care till arrival to the ED. So what things should have to be done on the phase 0? One of the things is just controlling hemorrhage through different action, like they can control the mechanical compression of the bleeding through gauze, topical hemostatic agent. They can possible to use, if available, topical hemostatic agent, extremity tourniquet, junctional tourniquet, abdominal aortic tourniquet, pelvic binder can also be applied in the peri-hospital setting. Coming to the phase 1, the main focus is just to control bleeding only. They go to the OR to control bleeding as soon as possible. So here in the OR, airway has to be secured. The patient should be ventilate with 100% oxygen and warmed fluids, and patient also get warmed so as to prevent the treble threats of trauma. Hypothermia is one of the treble threats of trauma during this time. At the OR phase 1 phase, patient can benefit from the warm fluids, as well as they can go surgery for stopping the bleeding. Here the main focus is just to prevent the coagulopathy, the hypothermia, the acidosis. And another important institutional protocol to have in place is massive transfusion protocol, since patient may lose a lot of blood. For that matter, we need to activate the massive transfusion protocol team if available. So there is no time to wait for the study result or the additional investigation or for consultation. Generally, as a trauma team, they go direct to the OR. Here, we don't have time to investigate the patient. And large volume of crystalloid will worsen reperfusion injury, augment inflammatory response. So they promote acidosis, dilute coagulation factor, and disturbs the inflammatory mediator. And administration of synthetic colloid will even further increase the coagulopathy by impairing all the fibrinogen polymerization plus the platelet function. And if hemorrhage is definitely controlled, once hemorrhage is controlled, some consensus recommend for transfusion is just hemoglobin 7 with patient having like cardiopulmonary cerebral peripheral vascular disease. The target should be hemoglobin of 10. It's a lot of recommendations. Some say 6 to 7 is the target for the normal adult patient, and it's labeled as 10 for those having cardiopulmonary cerebral or peripheral vascular disease. Generally, the hemoglobin between 6 to 10 is needs clinical judgment for transfusion. So another concept is massive transfusion protocol. So massive transfusion protocol can be defined retrospectively, like a patient needs 10 units of packed RBC within the first 24 hours of injury. But this doesn't make sense since it's a retrospective definition. It's better to define like whenever a patient needs 3 units of per hour, we can say that the patient needs massive transfusion protocol. So we have a lot of tools that which patient needs massive transfusion protocol. From those tools, the commonest what used in the emergency department is the assessment of blood consumption score, which is the commonest. So the assessment of blood consumption score has been validated, and it's easy to use and to predict those who are going to need a massive transfusion. It has 4 components. One thing, whenever a patient sustains penetrating mechanism of injury, we'll score 1. If yes, and if no, we'll score 0. And if a patient had positive first examination, we'll score 1, and if no, we'll score 0. And systolic blood pressure of 90 or less. If yes, score 1, and if no, 0. And heart rate of 120 as a threshold. And if we get 2 out of these 4, we can say that this patient needs 75% sensitivity and 86% specificity patient going to need a massive transfusion protocol. So one of the components of the massive transfusion protocol is the packed RBC. So using only packed RBC in patients with traumatic shock is ongoing without plasma and platelet will do little for because packed RBC generally has no component in the prevent the coagulopathy. So it's just only to restore the tissue oxygenation, rather it doesn't do anything to promote hemostasis. And generally, these are the 3 types of resuscitation strategies that applied in the damage control resuscitation. One thing is restricted resuscitation protocol. It's just to mean hemostatic resuscitation protocol, which limits the volume of fluid administered. Another delayed resuscitation protocol. It's just to mean delayed resuscitation till the hemorrhage is controlled. And another is hypotensive resuscitation protocol. As previously discussed, titrates to the low normal. So the best ratio of the massive transfusion protocol between packed RBC platelets and plasma during MS is still controversial. There is no clear answer, but experts advocate the use of 1:1:1 ratio, which there is no still clear answer which one preferable, 1:1:1 or 1:1:2. But according to the expert recommendation, they recommend using 1:1:1 ratio. So another component, which one is preferable? Is it fresh whole blood or component therapy? As we know, whole blood is physiological. To mean just it has all components of the blood rather than the component therapy. So the patient, if patient can go to fresh blood, particularly so for those blood who have age of less than 7 days, they may benefit from not only from the RBC, but also from platelet and from other coagulation factors. For that matter, fresh whole blood makes sound for resuscitation than that of the component therapy. So Another new advancement is just tranexamic acid, as previously discussed on the pathophysiology of the trauma-induced coagulopathy. Within the 30 minutes of trauma, traumatic induced coagulopathy or traumatic DIC can happen. For that matter, so as to act on the antifibrinolytic effect, tranexamic acid nowadays is advocated if the patient presents within 3 hours of trauma. That's just recommended on the crash tutorial. So guidelines nowadays approved to use this tranexamic acid if a patient present within the 3 hours of trauma. So regarding the dose, we can load with 1 gram in 100 ml of saline to be infused over 10 minutes and to continue the maintenance 1 gram in 500 ml saline infusion over 8 hours. This tranexamic acid may have adverse effect of hypotensive, dizziness, nausea, vomiting, diarrhea, and seizure, particularly for high dose. And the contraindication to this text there is allergy and acute vascular occlusion event. We can use nowadays, it's available even in the peripheral pharmacy. So another concept is the importance of calcium in the mass transfusion protocol. As we know, whenever the blood got stored, they use preservative citrate. That citrate going to chelate the calcium, and for that matter, life-threatening hypocalcemia will happen. So as to prevent that, we need to supplement calcium, and we need to follow the ionized calcium while doing massive transfusion protocol. So here, which agent is preferable, calcium chloride or calcium gluconate? We can use for 3 units of blood transfusion, we'll supplement 10 to 20 ml of 10% calcium gluconate or 2 to 5 ml of 10% of calcium chloride. But which agent is preferable is, as you know, calcium gluconate needs a good perfused liver so as to liberate calcium from gluconate. For that matter, it's better to use calcium chloride than that of calcium gluconate, since trauma patient may have liver injury as well. So it gets benefit from the calcium chloride rather than the calcium gluconate. And as well, the same is for like liver injury patient having liver failure. It's better to use calcium chloride because calcium gluconate needs a well-perfused liver so as to liberate calcium from the gluconate. And the target of ionized calcium is above 0.9 while doing the massive transfusion protocol. So coming to the phase 2, which is called the partial hemostasis, can happen in the operative theater and ICU as well. In phase 2 dynamic of the phase slowdown, patient got a little bit stabilized and the process become less blind and the patient need should be reanalyzed. So a mainstay during phase 2 is just utilization of point of care testing of coagulopathy to guide resuscitation. Just as the pillars of perioperative coagulative monitoring, we need to take the patient medical history, whether the patient is on like anticoagulant or was any bleeding disorder. We need to check that one, and we need to check the clinical presentation of the patient. We need to do standard laboratory coagulation test like PT, PTT, INR. And we can also do the point of care coagulation test, thromboelastography. So point of care coagulation test is a technique used for the characterization and quantification of the status of the patient coagulation status. So thromboelastography can be used to measure the hemostasis by studying the strength and elasticity of the clot and how quickly the clot break up. But it's expensive. It's not available in everywhere. For that matter, they lost. It's important for resource-limited countries. So another phase is the phase 3, which is called restoration of the physiology. In restoration of the patient physiology, this should occur once surgical hemostasis is complete. The dynamics of the resuscitation is now under control. So damage control resuscitation principle no longer apply here. There is no permissive hypotensive resuscitation protocol here, since the hemostasis already secured and we need to stabilize the patient to the normal level of blood pressure here. We don't hear about bleeding from resuscitation here. So we need to continue with serial point of care coagulation test. ABG should be done, thromboelastometry if available should be done, and if not, we can do coagulation tests like PT, INR, and PTT. Hemoglobin, hematocrit, fibrinogen should be determined on the phase 3. So, and the last one is damage control surgery. With the MER, the goal is just to minimize the time in the operating theater, limiting further bleeding, heat loss that allow time for a patient to be resuscitated in the ICU, and to correct physiological and metabolic arrangement before planned return to the OR. So the first damage control surgery, the main goal is just to minimize and to control bleeding. While they go to the OR, just either they go to the OR, either they can do devascularization or ligation or packing out the first time after they go to the OR. So only critical intervention should be done during damage control resuscitation, damage control surgery, and the return to the OR can be planned between 6 to 48 hours. But the patient condition matters. If the patient stabilizes early, they can go early than these hours. And if the patient condition couldn't allow to reinsert the OR, they can further prolong the time. And by this time, whenever the patient tries to return for the OR, it's just for the definitive period closure. So here the take-home message is we should be able to now those who need this damage control resuscitation, principle of damage control resuscitation, like the hypotensive hemostatic permissive resuscitation protocol, the damage control surgery, and different phases of the damage control resuscitation, and the massive transfusion protocol indication, and the adverse effects. So these are the whole presentation. Thank you for your time. And if you have questions, comments, you're welcome.
Thank you very much, Dr. Zeynu. I believe we have only one question written in the Q&A section. You can move to that and address that, I guess.
Okay, the maximum volume of fluid to be given for actively bleeding patient. According to the advanced traumatic life support, there is no recommendation to give more than a liter of balanced crystalloids. And the main focus is just to keep blood pressure to the low normal range, 80s and 90s, so as to avoid further bleeding for a patient till the hemostasis is secured. So shall I discuss the previous question?
Yeah, please do. 2 participants answered the question, I believe.
Okay, question.
So Lydia Sisai responded with resuscitation of the patient with 1 liter of warm normal saline, then blood transfusion. And Lydia Danye answered with continue fluid and request for O negative blood emergency, and try to compress the bleeding area and apply tourniquet if required, and start tranexamic acid. Sorry.
Yeah, so here the main focus, a patient sustains polytrauma patient present with hypotensive, he was on fluid. So the mere, like the target of the blood pressure as previously discussed is just 80s and 90s. We don't go beyond that. So this principle can do till the hemostasis is controlled. The patient can go to the operative theater, and till the hemorrhage is controlled, we can give fluids or bloodies to the systolic blood pressure of 80s and 90s. We shouldn't go beyond that. And another thing this patient needs is the activation of the massive transfusion protocol as a team. Previously discussed ያደረግናቸው አሉ triggers የሚባሉ the assessment of blood consumption scoring system አለ. That's the easy one. You can use ultrasound is available. Any fast positiveness or penetrating or blood pressure and tachycardia. Those are the things we need to consider. If the patient has 2 out of 4, you can request massive transfusion protocol, and this patient needs massive transfusion protocol. And while doing damage control resuscitation, the main focus is one thing, to prevent the treble triads of trauma, coagulopathy, acidosis, and hypothermia. So focus on the prevention of those treble triads. What if those treble triad happen should be addressed, like the balanced transfusion protocol, one-on patient. So those are the things we need to focus on that.
Okay, thank you very much, Doctor. As you can see in the chat box, there are a lot of appreciative comments. Thank you, and we hope to see you in another session. And thank you again.
Okay, thank you very much.
Good night.